much. I am delighted to be here, and more than that, thrilled to have been part of the Syntax trial, which was a landmark trial of a sort that we may never really see again. This trial was done in the era of the first generation of drug-eluting stents, and it's important to think back to what we all felt at the time. We had the results of some of the earliest drug-eluting stent trials, the pilot trials that had 0 restenosis and 0 events, and we didn't really know about stent thrombosis quite yet. So we really felt that drug-eluting stents had, even first-generation drug-eluting stents, had the potential to do anything. And that led us to this trial to all comers to compare PCI and standard bypass surgery in a randomized trial. And the only exclusions, effectively, were a recent MI or that either the surgeon or the interventionalist didn't feel that the patient would be suitable for randomization to either strategy. So if they weren't suitable for randomization, they could go into a registry, but the randomized trial remains the largest randomized trial comparing these two strategies for therapy. There has never been and may never again yet be a trial of patients with such complex coronary disease. You see the mean Syntax score was 28 or 29. The mean number of lesions, 4.5. 2/3 of the patients had 3-vessel disease and 1/3 had left main disease. I'm going to go right into the results, but a couple of other descriptive elements about the way the patients were treated are worthwhile. The mean stented length was about 80 millimeters. 1/3 of the patients had 100 millimeters or more of stented length. So again, you really have to imagine this is not 2-vessel disease, this is not FAME, this is a unique trial in terms of the complexity and severity of disease. So the 3-vessel disease cohort, you can see about 1,000 patients randomized, and the initial primary endpoint 1-year results showed no statistical difference in death, stroke, or MI, and as you see here, a significant difference in repeat revascularization favoring bypass surgery. When you look at the patients in the 3-vessel disease cohort, stratified by complexity of coronary artery disease, defined by Syntax score, the patients with low Syntax scores did not have a significant difference in total MACE or any of the endpoint components between stenting and coronary surgery. As soon as you got into intermediate Syntax scores, these are Syntax scores 23 to 32, there is a significant separation, including statistical differences in mortality, and acute MI, and the composite endpoints of death, stroke, MI, and total MACE. So this looks like a real difference. I should qualify this to say that the trial was not powered for any of these analyses. We always qualify them by saying that they are hypothesis generating or exploratory. But nonetheless, these are the findings, and they do make a great deal of sense within the context of our understanding of multivessel disease. And then, of course, the high-score patients with Syntax scores greater than or equal to 33 had a significant separation in events favoring surgery as well. So in summary, for 3-vessel disease, relatively simple 3-vessel disease did reasonably well compared to surgery, and more complex disease did not. This will be a similar exposition for the left main disease group. You see there are a total of about 700 patients randomized in the left main cohort. The 1-year primary endpoint results showed a repeat revascularization advantage favoring surgery, but obviously of a smaller magnitude than in the 3-vessel disease group, and a small but statistically important difference in stroke favoring PCI. When you look at the subgroups by complexity of disease, you see in the low score patients virtual overlap of the event curves with none of the components of the major adverse event endpoint being significant. In the intermediate score left main patients, similarly, complete overlap of the two event curves, and only in the high score patients, which are effectively left main and three vessel disease patients, do you see a separation in the total MACE driven entirely by repeat revascularization and not by mortality, stroke, or MI. So what do you do with all this? What does this mean for practice? This is sort of the big picture here, that the complex disease patients still make up about 2/3 of the broad population of multivessel and left main disease. This is not a pie chart of all of coronary disease, but specifically of complex left main with or without three vessel disease or multivessel disease without left main. So about 2/3 look like they're still primarily going to be treated with coronary bypass surgery. About 1/3 are going to be treated with either therapy by this reckoning, and then a small proportion are PCI only, and these are patients who have comorbidities that make them unattractive for surgery. Now, those are the overall results. One thing that we lose sight of in multicenter trials is the heterogeneity of performance by site. So this shows the major adverse event rates of PCI versus surgery in individual sites. The bubbles are proportional to the number of patients enrolled by site. And you can see some sites that have very high surgery MACE rates and very low PCI MACE rates, and vice versa, and some that appear well balanced. And I think it remains critical that we interpret large trial results with a lot of recognition that there is this heterogeneity. So the last thing I want to emphasize is that the syntax score is only useful if you use it. I would urge all of you to go to the syntax score website. It's free. It's pretty self-explanatory. Takes a little bit of practice to learn how to do the scoring, but it's a very, very useful tool. So in summary, when we look at these data in the 5-year, with 5-year results, bypass surgery should remain the standard of care for most patients with complex lesions who have high or intermediate syntax scores. For lower disease syntax scores or left main disease with lower intermediate scores, PCI is an acceptable alternative. And this trial was done with a heart team approach, and decision-making, collaborative decision-making remains part of the therapeutic strategy.